Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach. And this is another episode of Dadvice TV Live. And tonight, boy, this is going to be a popular topic. Now, for those that are new, I'm your host. I'm also a kidney patient. I was diagnosed with stage 5 kidney disease just over 2 years ago. And I've been lucky. I've worked on my diet, I've become more active, and I've improved my overall health. And along with that, my kidney labs have improved too. Most importantly, I got rid of every symptom out there, and I'm not tired. I'm not being held back by my kidney disease. Now, my kidneys, they're still in trouble. They're still shot. I'm not, running marathons or anything like that, but I'm able to do everything I want without my kidneys holding me back. Now tonight, our guest, you guys know him, you guys love him, Dr. Rowe. Hey, Dr. Rowe, how you doing?
I'm good, James. Happy New Year.
Hey, Happy New Year to you too.
Let's hope 2021 will not be anything like 2020. It was a tough year for most people. Yeah.
Exactly. And for those who are new, tell them who you are and about your book, Learn the Facts About Kidney Disease.
Well, I am a retired kidney specialist. I've taken care of kidney patients for over 40 years, and I did kidney practice as well as kidney research. I've got over 100 publications. A lot of my publications are very widely cited. And I've done a lot of work on the issue of when is the best time to start dialysis. And that was one of the motivations to get that information out to patients. So I decided the best way to get it to patients is to write a book about it. And also to get people to not worry when they don't need to worry about their kidney problem, because most people have very, very mild, if any, kidney problem, and don't really need to worry about it. And we'll discuss that in a few minutes.
Awesome. In your book, Learn the Facts About Kidney Disease. Guys, if you guys have not read this book, this, in my opinion, is a must read for kidney patients. One of the things it provides is that peace of mind based on your experience over 40 years working with people that have kidney disease. And like you mentioned, a lot of people, and I was one of them, got over worried about some things that I didn't need to worry about. Now, I was stage 5. I had things to worry about, but I focused on some of the wrong things. And I wish I would have had your book back then. I would have rested a lot more easily those first few months as I was figuring things out. Now, the thing we're here to talk about today is something that all kidney patients are all hopeful for. When can kidney function get better?
Exactly, James. And I think I want to start out by giving everybody the latest research. We discussed this in a prior talk, but I want to give you the list of a few things that have been shown to slow your decline of kidney function. That's not what our topic is tonight, but I want to start with that.
Nobody's going to say, don't tell us.
The most recent evidence from most recent publications are if you decrease your weight, all of these things may slow, nothing guaranteed there, but these things are associated with a slower decline. Decreasing your weight if you're overweight. Decreasing the salt in your diet, and we eat way too much salt, especially in this country and around the world, many countries. Plant-based diet can help slow decline. Plant-based diet, big supporter of that. Stop smoking. Stop smoking. It can help slow your kidney decline, as well as clearly the best thing you can do to live longer, no question about it, and keep your family healthier, because secondhand smoke is going to affect anyone around you. And controlling your blood pressure. So those are some of the top things to consider when you want to slow your kidney decline. Now we're going to talk about, changes of kidney function, recovery of kidney function. And let's start out by saying that you're going to look at all kinds of testimonials online about people who say their kidney function has recovered. But that is just because they had something we will talk about in a minute, which is called AKI, acute kidney injury, which means that you have a temporary large decline in kidney function. And we're going to talk about that in a couple minutes. Before we do, let's review a couple of things about what is abnormal kidney function. As we've discussed several times, and many people worry about their kidney function because they have stage 3A, which is roughly 45 to 60 on your eGFR, your kidney number. And as I've discussed with you, if you are under 60 and you are in the age range of 45 to 65, that's kidney problem. If you are under 75 and your kidney if you're under 45, if you're younger folk and your kidney number is less than 75, that's abnormal. And if you are under 70 or so, you got to be under 45 to really have abnormal kidney function. Now, why do I say this? The number is just a number. And why do we even get the number of your kidneys? Because it predicts whether you're going to get vascular disease, heart attacks, strokes, heart failure, and kidney failure. If your number is not going to predict that, it doesn't mean much. It doesn't mean anything at all. So if you're an older person and you are above 45, it may not even be abnormal. The main thing, as we discussed, is one number is not kidney problem. You need to have a repeat of the number at least twice in a 3-month interval. And let me tell you, when you look at all of the testimonials and someone says, well, I went from 80 to 60, it could well be the same number. Once your number is above 60, they're unreliable. It's very variable. You'll get numbers, one day it may be 70, one day it may be 80, one day it may be 60. So you need the trend over months and years, and you need to also, as we talked about several times, know if you've got protein in the urine, because that's the biggest predictor of losing kidney function rapidly. And the people that wind up getting to stage 4 or 5, which is less than 30, generally there's a high rate of protein. And the people that have 45 to 60 and no protein, and especially if you're 70 or 80, not to worry, not to worry.
Exactly.
Yeah.
I wish doctors would include age whenever they talked about the eGFR, because that is such a critical part that's missing. And someone, I get lots of emails from people who, they're well over 60. They may be at 80 in their GFR, and they're 70, 80 years old, and they're worried. And they really don't need to be. They just need to keep an eye on it and watch the trend. And there's such a good chance they may not have any kidney issues. It's just that natural decline.
Exactly. Yeah, I mean, there's not to worry when you're in your 80s and your number is around 60 or even 45 to 60. Probably not an issue. And in order to have a valid number, you need to have stable conditions. And you need to be on roughly the same diet, and you need to have, you can't be sick, because if you're sick, and that's what we're going to talk about next, your kidney function can change when you get sick.
And can't be dehydrated. I know so many people that are dehydrated and don't even realize it when they go and get their labs and there's a swing in their eGFR downward.
But James, I see a lot of people say, well, I'm going to get my kidney number. I'm going to drink a bunch of water today to get my kidney number down. That's nonsense. Don't do that.
Exactly. And especially if they try to do it while they're on their way to the hospital, All they know is a belly full of water.
No point. Pointless. And drinking a lot of water is not going to slow your kidney decline. Pointless. No need unless you have kidney stones. So the commonest reason for a patient to come to a kidney doctor is AKI. It's a change of your kidney function over a short period of time. Came up with a name called acute kidney injury. And as James just said, the commonest cause of this decline is dehydration. How do you get dehydrated? You get dehydrated when you have an illness, you have fever, you have diarrhea, you have vomiting, you haven't been eating, you haven't been drinking. That's the commonest way that your kidney function is going to decline or look like it's declining when it's just needing some more salt and water or saline. And what a lot of people do when they get sick and their kidney number looks terrible, you go into in the emergency room, they plug you into an IV, give you salt water, and you're as good as new. Your kidney function number comes back. So a lot of the testimonials where people have said, my kidney number went from, 30 to 60 or whatever, may well have been an acute insult. They may have had acute renal failure, and whatever they think got them better may not have had anything to do with whatever the woo-woo they bought online or whatever the thing they swore to, whatever someone else sells you. It probably wasn't that. It was probably just a state of hydration. And there's other things that we're going to discuss in a minute that can drop your kidney function.
So if we kind of look at my experience, and I think I had compounded real kidney issues, chronic kidney disease with AKI, some acute injuries that made it lower. When I went into the ICU, my first GFR was 8. IVs, they're hooking me up. My potassium was critically low. I remember it says critically low on the thing. They gave me potassium and stuff. And it quickly got up to 13. Now, thinking back, 2 weeks before I was in the ICU, I couldn't keep anything down. I know I was dehydrated, but I didn't tell them that because I didn't think about it. I was vomiting. I had diarrhea when I could eat something. I was afraid to eat or drink. I did drink a little bit of like a sports drink. I would sip it at night. I would nearly freeze it and sip it. And that was like the only stuff I got, for almost 2 weeks. I got very little food, fluids, but I expelled a lot of them. So that jump from 8 to 13, most likely I was dehydrated is what it sounds like, what I believe.
Well, and here's something. Most people, like I said, have stage 3A, 45 to 60, most of the kidney disease. But if you have more advanced, if you're 3B, less than 45, or you're stage 4, less than 30, a little bit of dehydration can really push your creatinine up very quickly. It can go up a little bit of dehydration can change your eGFR quickly from 30 to 15. And you hope that you're not going to get the wrong doctor who's going to say, well, you're 15, I want to plug you into dialysis.
That was my
doctor. Be sure.
She wanted to put something in my neck.
Be sure that you ask your doctor if your kidney function worsening is reversible. And let's talk a little bit about some of the reversible things. So the way I talk about it in my book, I talk about your tank. Your tank is you want a full tank. What's a full tank? It's your blood volume. What's your blood volume? It consists of your red blood cells, or all the other blood cells, but primarily your red blood cells and the fluid, which is called plasma. And when you get dehydrated, your tank is not full. And when you go into the emergency room and get some saline, like James got, it fills your tank up and your kidneys get happy. What do your kidneys try to do when your tank is low? It tries to hold on to all the salt and the water that it can. And some people call acute kidney failure acute kidney success. Because think about this. just about all of your blood volume goes through the kidneys, and the kidney reabsorbed almost 100% of it. If it didn't, you would have no blood pressure. So the kidneys are very important to maintain, we call homeostasis, big word, the balance of the fluids and the electrolytes in your body. So, and like I said with James, if he already has an abnormality, if you're already stage 4, it doesn't take much dehydration to put you into stage 5. You can go from a 30 to a 10 very quickly with a little bit of dehydration. And that number, when it's changing, is unreliable. You have to have a stable situation. You have to have stable state of your tank in order for the number to be reliable. It may be just a reversible situation of an AKI. And I put an example in my book of a patient who came in. Well, before I tell you the patient, there's a type of AKI which is very serious. It's called ATN, acute tubular necrosis. And this is a severe type of acute renal failure, and it's usually due to a drop in your blood pressure. If you get dehydrated severely enough, or if you lose blood, you bleed from an ulcer, or you, God forbid, have an accident and you're bleeding and you're not getting enough blood back to your kidneys and enough salt water back to your kidneys, the kidneys are going to shut down. They're not going to function. But this is a temporary, it's reversible cause of kidney failure. And a lot of people will go on dialysis with a severe ATN, and most patients recover from it. So even if your kidney function is terrible and you need to be on dialysis, if you've had a really severe situation with very low blood pressure, severe dehydration and vomiting, and you go on dialysis short term, kidneys generally will recover. And what I do with my patients is I just have them, once I see, so if you get the severe type of kidney failure, your urine output drops dramatically. So you're not putting out enough urine, and so you need a machine to help with the fluids. And when I see the kidney function start to recover, I will have the patient have the lab checked in the hospital every day, because don't forget, you have to, once you're on a machine, the numbers are not useful. You've got to be off the machine to see what the real number is. So I'll take the patient off the kidney machine and follow their kidney function. And then I'll have them come back maybe once a week to make sure the kidneys are coming back to where they need to be. So that's acute tubular necrosis. You got any questions, James, before we go into the next type of AKI situation?
We do have some questions, which I'll come back to later, that are related to kidney disease, but not exactly to AKI right now.
So let me give you the other common situations where a patient will have a marked drop in their kidney function, which is reversible. This will happen if you're on certain medications and you get, especially if you're dehydrated and you're on these medications. What are these medications? They're the common things we use for aches and pains. The NSAIDs, which are non-steroidal anti-inflammatories. You'll know them as ibuprofen, Aleve, Motrin, naproxen, Advil, Celebrex, and even very high dose of aspirin. If you're on these kinds of drugs, especially if you're on them and you get dehydrated, your kidneys aren't going to be happy, and they may temporarily have a decline of kidney function, which when you give patients the salt water and you stop the drugs, most patients will recover their kidney function. The other types of drugs, and this is a little bit ironic, that can often cause acute kidney injury, short-term drops in kidney function, are the drugs that can protect you from losing kidney function. They're the ACE drugs, angiotensin converting enzyme inhibitors, ACE, and the ARB drugs, angiotensin receptor blockers.
I had a non-stop cough. I was on that losartan. I was on it and one other pill for my blood pressure. Now I'm on a bunch of pills. Morning dose, late afternoon dose.
Actually, James, the losartan is the one that they would give you if you get the cough. The TANs are the ones that don't give the cough, generally speaking. It's the prils that give you the cough. But okay,
maybe I was on I can't remember. I do remember having losartan at one point.
Yeah, that's the one they would have. Yeah.
And they took me off of it. But to get my blood pressure under control, they went through so many different combinations.
But what they might have done, and this happens all the time, James, is if you've got a decrease in your kidney function and your doctor puts you on a ACE or an ARB, very commonly kidney function declines. It's one of the commonest causes of drug-related acute kidney injury or decline of kidney function. But here's the irony. If you have protein in the urine, if you got over 300, in Europe you divide that by 10 because they're in millimoles, not milligrams. If you're over 300 for the US units, so you have macroalbuminuria, these drugs are the best drugs to slow decline. So what do if your kidney function declines? And now if you didn't have protein, James, and you're one of my patients and you didn't have protein in the urine, I would probably stop the ACE or an ARB, because if your kidney function dropped with the ACE or an ARB, I would stop it. But if you had a lot of protein, and even if it dropped 30%, I would continue to follow you on the drugs to see if your kidney function either recovered or stabilized. Because over the long term.
Yeah, I did have protein originally. I know it was over 300, but not astronomically high. And then it quickly got down lower over maybe a month or two.
Yeah.
To where eventually it became below 30 is all it would say.
Right.
It was below 30, normal or something like that, within range, something like that.
Well, the protein, just like your kidney number, needs to be repeated at least over 3 months to confirm that you really have the protein in the urine. Just like you got to confirm that you have an abnormal eGFR. Because when you're ill, you may have been ill with high protein due to your illness in the urine. Mm-hmm. It may not be due to a typical structural problem in the kidney that can cause protein in the urine. And that leads me to, I forgot to mention, three types of acute kidney injury or acute renal failure, temporary drops in kidney function. They can be pre-renal, before the kidney, and we're discussing that now. Mm-hmm. These are the dehydration. You're not getting enough flow to the kidney. These can be some drugs that affect, the flow coming into the kidney. So that's pre-renal. We're going to touch on post-renal, which is mostly, blockages of the kidney. And then there's acute kidney injury. These are very unusual causes that are in the kidney itself. And we're not going to discuss them because they're very unusual. Things like called acute glomerulonephritis, acute interstitial nephritis. Sometimes people take a drug and their kidney gets damaged from it. Sometimes there's a rare cause of a disease in the kidney, certain systemic diseases like lupus you may have heard of and other things. But those are rare. We're not going to really discuss them this evening. So another type of drug, which is very commonly used, that can give a short-term decline in kidney function, are the GERD drugs, the heartburn drugs. And many, many of you are on those drugs. These are things like Prevacid. These drugs are the azole drugs, like lansoprazole, Prilosec, omeprazole, and Nexium. These are the GERD drugs, and they have been connected to declines of kidney function. And my recommendation to you, if you have abnormal kidney function, is to stay off of the PPIs, proton pump inhibitors is what they're called, and use the TUMS, use the antacids, eat small meals, try to lose weight, and cut down on your alcohol if you've got GERD, a real common problem. But you want to try to...
This is the first I've ever heard that, and here's what's funny. I had such bad upset stomach. I was taking like everything that I could. The Pepcid AC, drinking Pepto. So it sounds like some of that may possibly have even artificially lowered my kidney function, on top of being dehydrated.
Yeah.
And I was taking ibuprofen long term.
Okay. Perfect, Jay. This is a perfect introduction to an important concept. Often there's multiple causes of your short-term decline of kidney function. Number one, if you're going to take one of these drugs that can affect your kidney, whether it's the ACEs or the ARBs, whether it's the NSAIDs, whether it's the drugs that James just mentioned, the proton pump inhibitors like Prevacid, you want to stay hydrated to keep your kidney from getting a decline in function. You want to stay hydrated. Kidneys want to keep hydrated. That's how you can protect them from this acute decline, the short-term decline. But you don't ever...
My doctor never asked about any of those, which kind of shocks me. The original doctor, which once I got out of the ICU, I got a different doctor. Because all she wanted to do was hook me up, put something in my neck, get me on dialysis right away. And it sounds like, she didn't ask me enough questions and I didn't share enough information to discover that I may have been causing the lower kidney results based on doing multiple things that just were not good for me that I didn't realize.
Anyone, especially if you go to a kidney doctor should review your medications because there may need to be dose adjustment as kidney function declines. Certain medicines need to decrease the doses because they need the kidney to get rid of them, to excrete them. And there are lots of medicines that could be adversely impacting your kidneys. And the first thing any kidney doctor should do when they see that you've had a bump in your creatinine or a drop in your kidney function is look for reversible causes, especially some of these drugs that we're talking about. The next thing we'll mention, which used to be a really big problem, is when you get an x-ray with contrast. And back in the day, lots of diabetics were getting something called coronary angiograms to look at the arteries in the heart, because if you're diabetic, you tend to have a much higher risk of having hardening of the arteries. When they would get contrast for these coronary angiograms, their kidneys would shut down, and a lot of them wound up on dialysis. It was almost an epidemic proportions. But we got smart. We have other agents that we can use for x-rays, and we know how to protect the kidneys. Very simple. Push the salt water. You can protect the kidneys by keeping them well hydrated, and if they're going to get an insult like contrast, you won't get into acute kidney failure. And the more recent contrast agents are not causing the kidney failure like they used to do back in the day. But here's one thing I will tell you. If your doctor wants to do an x-ray with contrast, and you've already got abnormal kidney function, ask your doctor, what is the risk versus the benefit of doing this x-ray and potentially putting my kidneys in harm's way? If there's a good reason to get it, protect your kidneys and get it. But if it's an optional thing to get, then I wouldn't do it. You need to discuss that. Now, there's a rare problem that happens when you get an MRI. MRIs, there's a material that they use for contrast. It's called gadolinium. And there's a rare, very serious adverse event where you get something called, big term, nephrogenic systemic sclerosis. Basically, it means that you get fibrosis, you get fibrous tissue in your skin and some organs of your body. It's very rare, and it's mostly a concern if you're stage 4 or 5. If you're not stage 4 or 5, the MRI may be fine, but your doctor should be aware of that. The last thing we're going to discuss, which is very important, is one of the most common reasons people go on dialysis is congestive heart failure. Now, what do I mean by congestive heart failure? That means you've got a weak pump, you've got a weak heart. And it's one of the commonest situations where people are started on dialysis. So if you have stage 4, half of you may already have some weakening of your heart, very common. So what happens if your heart is weak? If your heart is weak, you probably have a full tank, right? We talked about having a full tank. But your pump is not getting enough pressure to the kidneys. So what are the kidneys going to do? They're going to continue to reabsorb and put back in the blood salt and water. And what's that going to do? It's going to cause edema or swelling. And the best way to check for the edema is take your index finger and push it on your ankle or just above your ankle and hold it there. If you can push it and you see an indentation, there's other reasons besides this, but most commonly if you're already in a heart failure patient, it means you have total body excess salt and water. So what do we do about it? Well, the way we treat heart failure is we give diuretics. Now, I didn't mention this, but a common situation, let's leave the heart failure out, besides taking the NSAIDs, besides taking the ACEs and the ARBs, is if for some reason you're taking too much diuretic, you can get dehydrated from that. So sometimes patients' kidney function can look like it went down because they got too much diuretics. But if you're a heart failure patient, you're going to need those diuretics because sometimes if you can't get rid of that extra salt and water that the kidney is going to reabsorb because that pump is not getting enough pressure to it, you may have shortness of breath. And in order for you to breathe more relaxed and easily, you're going to be on diuretics. And you're also going to be on the wonder drugs, not just for slowing decline of kidney function, but the ACEs and the ARBs are great drugs for long-term benefit, better survival of patients with heart failure. So what do we do? And this is a very common situation. You'll come in, especially if you've got a really weak heart, you may come in the hospital, you may have to get drugs to get the heart stronger, you may be on a lot of diuretics, and your kidney function may go down. But here's something really interesting, James. It's been shown that if your kidney function even goes down 50%, let's say that you went from 30 to 15 and you're a heart failure patient and you've been on the ACE or an ARB and you're on high dose diuretics, well, you don't necessarily have to start dialysis at 15. If the ACEs and the ARBs are keeping your kidneys at 15 and you're breathing fine, you're taking all those diuretics, your long-term survival is probably going to be better taking the medications and not subjecting yourself to being on a dialysis machine than what is often what happens to people when they get around 15, they've had heart failure, we're going to put you on a machine. So you may be better off conservatively being managed. Now, of course, this is something every patient needs to individually be assessed by the heart specialist and your kidney specialist, but it's very common. Your kidney function can often decline with heart failure from the treatment. but it could be temporary. And if your heart gets better, your kidney function can get better as well.
Mm-hmm.
But if you need to take the ACEs and the ARBs and the diuretics for you to function better, that's what you may need to do. And you may have to live with a little bit lower kidney function number, but that's not going to, affect your lifespan. Your lifespan is going to be primarily influenced by how your heart is doing. You have any questions before I give you the last?
Nope. Go ahead and give us last. Well, I'll add one other point in there.
Yeah.
Every time I go in to see my doctor, the very first thing they do, whether it's my nephrologist or my family doctor, is they look at my ankles. They're squeezing on it and letting go. And I know it's for looking for, my fluid. But I never realized just exactly what they were looking for. I always just, is it squishy? Is that what they're looking for? So that's very
James,
interesting.
So here's one of my rules of thumb.
Mm-hmm.
When I'm trying to assess a patient for dehydration, I check for edema. Like I just said, put my finger, hold it there, and see if I get an indentation. It's a pretty simple test. It's not the most sophisticated or best way.
Yeah, but it's easy.
If I see that indentation, and I'm trying to decide, is this patient dehydrated? Probably not. In other words, when I'm trying to assess if your decline of kidney function is due to dehydration, my simple test for edema is one indication that you're not dehydrated.
Yep.
Now, another thing that we didn't touch on, in addition to the diuretics and so forth, is your blood pressure drugs. I can't tell you how many patients have had acute renal failure because they overtreated themselves with blood pressure drugs. And that's why I tell people, take your blood pressure medicines at night. They may have the most benefit long-term by taking them at night. And most people, and just about anyone that I still treat people, by the way, in the free clinic. People that I treat with once a day. It's almost rare. It's pretty unusual that we have to use blood pressure drugs more than once a day. Some drugs are twice a day, but at the maximum twice a day. But if you're on once a day, I give the patient the drugs at night. But if you are feeling weak or dizzy, please check your blood pressure. If your blood pressure is not at least 110 to 120, you may need to just hold that blood pressure medicine dose and then recheck it the next time you're supposed to take it. And make sure that you're over, let's say, 120, 130, or 140, because if you keep taking them and you're 110 and then you take it, it may go to 100, and then you keep taking it, it may go to 90, and it may go to 60, and you are in acute renal failure. So be careful. If you're feeling weak or dizzy, be careful not to overdo your blood pressure drugs.
Yeah, and I don't think a lot of people realize that your blood pressure is kind of what's powering your kidneys. If it's too high, it's bad. If it's too low, it's bad. There's a range where we want it to be so that our kidneys can operate right, because they're expecting that blood pressure to help them do what they do.
And like all the other things that we talk about that can affect your kidney function, it's long-term relationship between blood pressure levels and your decline. If your blood pressure levels stay within a certain range, and that range has been a moving target, because all the experts, and there's more and more studies that have come out, they say, well, it should be below 140. No, it should be below 130. There's been a lot of discussion and confusion. And we'll have another talk about blood pressure, not tonight, but my general advice is you want to get more aggressive with your blood pressure if you're one of these folks that is losing kidney function more rapidly. And when I say more aggressive, I'm saying a goal blood pressure, instead of less than 130, I would be shooting for 110 to 120. If you're one of these folks that has a good bit of protein in the urine, especially if you're a younger person and you're losing kidney function rapidly, keeping the blood pressure in that range over long periods of time will benefit you in terms of the rate of loss of your kidney function.
And you're talking about the top number, just to make sure everyone
Yes.
knows.
And don't get hung up on the bottom number. So just I think I may have mentioned this in one of our other talks. Back in the 70s, 60s, late 60s, 70s, we didn't even know about blood pressure. So the first studies came out in the VA. I did my career in the VA. I wasn't involved with the first blood pressure studies. But they randomized controlled trials, placebo versus drugs. And you had to have a 130 on the bottom to get in. 130 on the bottom number.
That's so high.
Yeah. We call that malignant hypertension. At 130 diastolic. Anyway, long story short, we didn't know if it was going to benefit, and we quickly found out that less strokes, less heart failure, less kidney failure, and then they moved the bar down from one, and they were looking at diastolic. But then over the decades, we realized that systolic is much more important, the top number, than your diastolic blood pressure. So when I say 110 to 120 as a goal for people who are losing kidney function rapidly, that's the top number. Okay. The last thing we'll touch on is the post-renal. So we got pre-renal, which is the dehydration, the weak heart, the low blood pressure. The post-renal is going to be, so your kidneys, they're connected to two ureters, and each kidney has a ureter, and the ureter is going to your bladder, and the bladder comes out into the urethra, and then the urine comes out. So if you have blockage anywhere along there, you could get a worsening of kidney function. But in terms of kidney stones causing your kidney function to go down, it's unusual unless you block both kidneys, which is pretty unusual. Or you've got one kidney that's not functioning and you block the other kidney. So kidney stones often will not cause your kidney function, acute renal failure, because you can block one kidney and you're not going to know it necessarily by your kidney number. Mm-hmm. The other way, which is real common, especially in older men, is something called BPH, benign prostatic hypertrophy. The prostate, as we get older especially, gets bigger and bigger, and it can block the urethra, block the flow of urine out of your bladder. And it's amazing. I can't tell you how many patients, dozens, that have come in with acute kidney failure, kidney number down around 5 or 10, eGFR, and put a catheter in and empty out the bladder, give them some fluids. And even when it's long-standing blockage like that, there's recovery of kidney function, often way back to normal. The other post-renal situation where you're not going to get emptying of urine is if your bladder has some nerve problems, and which can happen in diabetics. It's called neurogenic bladder. And if the bladder doesn't empty and you accumulate urine, the urine can back up, and that could be another situation where you have acute renal failure, and that would be the post-renal cause.
So is the nerve damage removing that sensation that you have urine and you need to go and you're not emptying? Is that what the problem is there?
Well, it could be several things. It could be the muscle is not working because you're not getting enough stimulation of the muscle to contract it to empty it completely. Mm-hmm. It may be, as you just said, you're not aware of your bladder being full. So there could be various components to this neurogenic bladder problem. But the post-renal, I think, is going to be much less common for your audience. I mean, it's not something that's rare, but most of the time, the people that are following your program are probably going to have, my guess is, stage 3 or stage 4, and they're going to have an acute kidney failure, acute kidney injury situation, most likely due to lower blood pressure, dehydration, or a combination of that and some of the medicines that we discussed that can lower your kidney function. But again, when somebody says, and my kidney number went from 80 to 60, that could be total nonsense. And And if somebody said, I have a testimonial and my kidney number went from 15 to 80 or whatever, it could have been acute renal failure. So don't fall for the testimonials, because there are very few things that have been proven to affect the rate of decline of kidney function. And we've talked about them in our prior talks, and I mentioned some of them at the beginning of tonight's episode.
And one thing I like to mention, I was thinking about it earlier and I forgot, when you're talking about the diuretics, a lot of those, as you like to call them, woo-woo cures or woo-woo pills, you know, the things we all see all over Facebook that are going to help improve kidneys, a lot of those are diuretics, which some of them have been shown to be strenuous for the kidneys, not good for the kidneys. And if you're taking a doctor prescribed diuretic and throwing some of that woo-woo stuff on top of it, you could be hurting yourself. So make sure, guys, your doctor knows what you're taking. Just because you were able to buy it off of Amazon or off of Facebook or something does not mean it is safe for you to take. So be really, really careful for all those things out there. As a matter of fact, I do not recommend any of those kidney cures, kidney flushes, kidney restores, whatever they are. None of those. And if you need a diet, a renal dietitian, that's who will help you, because each of us are a little different, and a renal dietitian will work with you, the foods you like, and with your lifestyle to find a diet that fits you and your health.
James, along those lines, the National Kidney Foundation has a position paper. They strongly recommend against taking any herbal products or supplements if you've got a kidney problem. And here's the reason why. They are not regulated by the FDA, the Food and Drug Administration. To get a drug pass, whether it's a diuretic or a blood pressure drug or any other drug that you may be taking, the FDA has strict criterion to prove that they're safety and that they actually work. And most of the things that are being sold online as supplements or herbal remedies have not gone through these studies with large numbers of patients to prove that they work and to prove that they're safe. And they go through various stages. And I think if you're following the COVID situation, you can read about the stages that drugs have to go through to be approved, the COVID vaccine. It's a very complicated, very serious process. And the things, like James said, you could be on something that can interfere with your other medications. And there are some herbal supplements that actually cause kidney failure. I mentioned them in my book. So please stay away from them. There's no point to it. And if you need a diuretic, take the ones that have been safe and effective. And they're on the market and they're FDA approved. And we have years and years of experience with them.
Yeah. So guys out there, I know a lot of you guys out there, you're hoping there's some herbal thing, some magical concoction that nobody in the world knows about except this one company on Facebook that's running, tons of ads every single day, but no doctor's ever heard of it. None of that stuff works. It's just wasting your money, and you could be hurting yourself. I know you want it to work. I would love for there to be something, but there just isn't. Working with your doctors, working with your healthcare team, focusing on your health, your diet, your heart, like Dr. Rose said, let's lose weight. Let's get in shape. I'm overweight. I'm working on losing weight, trying to get better. I know my heart, even though I have kidney problems, I really got to focus on things that are good for my heart. And that's being active, losing weight, keeping my blood pressure under control, eating right, and pretty much just living healthy.
And James, just to reinforce that, people get hung up on your kidney number. The kidney number is meaningless by itself. Why did this whole thing come about where they get the stages of kidney and they tell people to know their kidney number? It's because it's just another one of the risk factors for developing atherosclerosis, hardening of the arteries, just as James said. You're not going to die. The vast majority of people with any stage of kidney problems don't die of kidney problems. It's the heart problems, it's the blood vessel problems. So you need to do all of the things that James has mentioned for living healthy: exercise, diet, stopping smoking, controlling blood pressure, controlling diabetes. because you want to live longer and you want to avoid the heart disease, which is the main thing that, knowing you have a stage of kidney abnormality, is that you're trying to prevent. You want to prevent that bad outcome.
Yep. And it's nothing magical that I know. That's what my doctors keep telling me. Focus on your health. Don't worry about your kidneys. They'll come along. Be healthy. Let's take care of your heart. Now, there's a quick question I would love for you to touch on. Olivia asked, is it safe to take the COVID vaccine? Can you talk about that? Because that's a very important topic.
It is not only safe, it is also essential, because if you go back to Dadvice TV, I talked about COVID. There is a large study that came out of the UK, several million people they looked at. And some of you may know that African Americans, Hispanics are at higher risk of dying from COVID. People with diabetes are at higher risk. But guess what? People with stage 4 and 5 CKD are some of the highest risk patients. So everybody should take the vaccine. It is especially important for people to take the vaccine if you have abnormalities of kidney function. And the vaccine is safe, it's effective, and it's something that has emergency authorization because the studies aren't complete, but there's no reason to fear it. There has not been any serious problems with it. If there were, the FDA and the UK, they're equivalent to the FDA, they would not have given the green light to these drugs that have been examined by many experts in infectious disease around the world, and everybody is fine with them. So take them, and this is the one way we're going to get out of this hellacious situation we are in, where so many people are dying every day from this terrible pandemic. So yes, take the vaccine, please.
Yeah, and I cannot wait for the day that I can get it. As a matter of fact, here in Cincinnati, they're setting up drive-through vaccination facilities not that far from me. Now, they don't have enough of them yet to open it up, but they, soon those will be available. My wife and I are going to go get it, and as soon as there's an approval for children, we'll get our kids to get it too.
Yeah, that's going to be a while, and luckily, kids seem to do well. We're very lucky. Could you imagine? This could be much worse if our kids were dying. Thank God the kids have rarely had serious problems.
Well, and my kids have definitely gotten into a very, very good habit of, as soon as we walk into the house, you wash your hands. They do their 20 seconds, and then they rinse it. They're not going out to places with crowds. They don't go shopping with us when we do go and get groceries. And our kids I only have 2 other families that we have in our bubble, and it's just 3 families. We're all in each other's bubble, and that's it. So we're doing what we can to be as, I guess, close to normal as possible during this. But oh boy, I cannot wait for the vaccine. And someone said, James, can you record yourself? I'm going to try, but let me tell you something. A lot of times when you're someplace, they don't want to wait for you to set up stuff to record yourself. And some places don't like for me to record myself. I've tried to record myself during my labs, just getting blood drawn. They don't like that. They don't even like it when I take a picture.
Do you want me to answer a question? If that's okay, James?
Sure.
Okay, yeah, so Eric is asking about a sister, patient at Children's Hospital. Children's Hospital will have a pediatric nephrologist. There is no such thing as a kidney specialist hospital, so that's fine. At a Children's Hospital, as long as you have somebody that's a pediatric nephrologist, you're fine. I'm looking at some of the questions there.
Yeah, there's any that you see that you want to answer. And while you're looking back on those, tomorrow night, everybody, Jen Hernandez will be here, and she is going to share her renal diet shopping list. Woo! That is going to be awesome. I know it's going to be a hot topic. I don't know if it'll be a download. I'm hoping there'll also be a download with that. And the schedule for upcoming Dadvice TV shows is on Dadvice TV. We got new people. We have a social worker who's now joined us. We'll be doing 2 shows a month to help people, and a whole bunch of other great stuff planned. Hopefully I gave you time to find a question, Dr. Rowe.
Yeah, well, one thing I want to mention, which will be a whole other episode, is there's a lot of excitement for diabetics, for drugs for diabetes that are showing really good benefit at slowing decline of kidney function and decreasing the heart complications of diabetes. So that's going to be another talk. So there's some good things on the horizon with regard to diabetic treatment, which can help slow kidney function decline.
Oh yeah, I'm excited. You've mentioned that a few times, that there's progress being made, and I cannot wait to hear about it. Especially knowing how many people have diabetes and it leads to kidney issues.
Yeah. So again, one thing, if you happen to know someone or you're a patient that has one of these acute renal failure episodes and you go on dialysis, I mentioned this before, make sure you ask your doctor if your kidney function has recovered. Because as I mentioned to you before, it's not a routine practice to look for recovery of kidney function with an AKI. And when you're evaluating your kidney function and you're trying to get the trend, you want to look at the trend after you have recovered from AKI and watch the rate of change of your kidney function over time.
I'm writing somebody back something.
Okay.
There we go. I'll pop it. Kay asked, am I going to be talking about lupus one day in the future? Yes, I am working on getting someone who knows all about lupus and kidney disease to come on and talk about it. I try not to talk about things that I don't know, because you guys will know if I don't know. I'll just be rambling on, mispronouncing everything.
All right, so let me answer a couple of quick questions before we get off. So Benadryl is fine. I highly recommend Benadryl for people that have sleep problems. 25 milligrams may work. You can go up to 50 milligrams. One thing to be aware of is that Benadryl will give you a dry mouth, especially at high doses. And for men, it may affect your ability to pass urine.
And what about melatonin? I take that.
That's fine. I don't have a problem with melatonin. I think it's safe. I mean, and I think it may be beneficial. There's not a lot of research on these things that are over the counter, but some people think it helps them, and I'm fine with it.
I use it. I haven't used it very often recently, but when I travel, I'll take a 3 milligram one. When I get to a new hotel, I can't fall asleep that first night. The temperature's not right, the noise, it just doesn't work. So I have to take that. And usually when I'm traveling, that means I'm getting up really early. So I need to get to sleep.
Question about pain. Kidney problems do not cause pain. Someone's got an extrarenal pelvis. That's just one of the many, structural anomalies, not anything problematic, and it should not cause pain. The only situation where people commonly have pain is when they have polycystic kidney disease, because the kidneys get extremely large, and in that situation they can have some pain. As far as diabetics and insulin versus pills, and this is a long discussion, but in general, people should not be started on insulin unless they fail at the oral agents. And that is a long conversation about when is insulin the appropriate thing to use. But I don't see any particular issue regarding insulin being more beneficial for kidneys than oral medicines. Although, as I will tell you, there are oral medicines that we will talk about. Insulin has not been shown to have any specific special relationship to slowing kidney function decline. These new medicines may. So that's going to be for another episode.
Very good. Well, we are at the top of the hour, Doc, so I want to thank you again for another great and informative show. And thank you, everyone out there joining us today. If you haven't subscribed yet, hop on over to YouTube and subscribe to the Dadvice TV channel. I hear some birds. Do you have pet birds?
That's my clock.
Oh, I was going to say they've never, ever.
It's an Audubon clock. And it has bird songs.
Hey, there it is. It is the top of the hour. But everybody, look for the broadcast list, upcoming shows on dadvicetv.com. Dr. Rowe will be back here in 2 more weeks with more great information. All right, everybody, thank you, and I will see you tomorrow. Bye, everyone.